Good evening, every aspirants present here and all the doctors. So today the topic is acute pancreatitis, in which the organizers are Akhilesh Tandekar, Dr. Gunadhar Padi, Dr. Asif Iqbal, and the speaker we have today is Dr. Indrajeet Tiwary, who is a head gastro and liver transplant critical care unit in Apollo Multispeciality Hospital, Kolkata. Also, we have the moderator here is Dr. BISWA BIKASH Mohanty, who is a senior consultant and HOD in critical care medicine at Utkal Institute of Medical Science, Bhubaneswar. We also have Dr. NEERAJ Kumar, who is an associate professor in anesthesia and critical care AIMS Patna. He will be joining us soon, and there will be many other students joining us. So, Dr. Indrajeet Tiwary, you may start the class and you may share the screen. Thank you.
Okay. So today we'll be going to discuss the management of severe acute pancreatitis. In allotted time, I will try to discuss what is acute pancreatitis, how we'll manage it, what are the difficulty in diagnosis, and what are the managing challenges out there, we'll discuss. And later on, we make a discussion, we take some questions also if you have. So today's agenda will be, after the introduction, how will you assess the severity of pancreatitis, fluid management, role of antibiotics, pain management, nutritional supplementation, any radiological, surgical, or any other interventions, and finally the summary. So first thing, what is acute pancreatitis? As the name itself implies, pancreatitis. That means there is inflammation of the pancreas, which is called pancreatitis. And acute pancreatitis, we used to tell it is like an accident. Anybody can have the pancreatitis without any alarming symptoms. That means sudden onset pain abdomen. So how will you diagnose in emergency or in OPD? What are the patient, how the patient will present to you? So there is a diagnostic criteria. Out of these three criteria, there should be at least two. That means typical pain. This pain is usually concentrating into the epigastrium of left hypochondrium, radiating to the back. Sometimes you may not get this typical pain abdomen, but yes, there will be pain. It may be diffuse, may be localizing, may be radiating, but in typical cases, what we get, pain epigastrium or hypochondrium radiating to the back. Along with that, if you are getting the elevation of serum amylase or lipase 3 times of the normal level, or any of the radiological feature consistent with pancreatitis. It may be USG, maybe CT scan, maybe MRI. That means one clinical symptoms, one lab parameter, and one radiological parameter. Out of 3, if there is just 2, suppose your patient is having pain abdomen and lipase amylase cutoff is 40 and your patient is having 200, 300, definitely we think we are dealing with pancreatitis. Sometimes in initial hours, lipase amylase may not increase, but if we are doing a ultrasonography and we'll discussing some condition where lipase amylase may not increase, but patient is having typical pain abdomen and any of the radiological features consistent with pancreatitis like bulky pancreas, necrosis or edema, inflammation, then we'll call it acute pancreatitis. So I think now definition is clear. How we'll call acute pancreatitis? Any patient presenting with pain abdomen or having lipase amylase 3 times or any radical feature. Out of 3, if there are 2 criteria met, we diagnose as acute pancreatitis. Now the severity wise, usually 15 to 25% of pancreatitis is severe in nature. That means 70 to 85% of the cases are mild to moderate in nature. And overall mortality of this severe acute pancreatitis is almost around 15%. Now, I am not going into the detail of the etiology of this pancreatitis. It may vary from the more commonly what we get is a gallstone pancreatitis, alcoholic pancreatitis, hypertriglyceridemia. Any sort of medication can cause pancreatitis. Any sort of viral infections can cause pancreatitis. Any surgical procedure can pancreatitis. So a lot of things are there. But most commonly we encounter that is gallstone pancreatitis, alcoholic pancreatitis, hypertriglyceridemia, some metabolic hypercalcemia or hypocalcemia. That means they long range. But what about the etiology? Once you diagnose acute pancreatitis, management part is almost same, except in few cases when you require a specific management. Otherwise, the initial hour management is same irrespective of the etiology. That means it is inflammatory state, and this golden hour, initial hours is very, very important, and you have the specific so-called protocolized treatment is there, and you have to adhere for that. So first and foremost thing come, how will identify the severity? Which patient is going to the ward, which patient you need the critical care area, and some of the center like my center, we have the specialty care like GI critical care, gastrocritical care. That means we cater this sort of patient more frequently, and you have to assess at emergency only which are the patients who require the ICU admission. So this is revised Atlanta criteria for severity of acute pancreatitis. So it mild, moderate, or severe. That means if there is no organ failure, absence of organ failure or local complication, we call it mild pancreatitis. If there is any local complication and or transient organ failure, what is transient organ failure? It is very, very important to remember. Any organ failure is not lasting more than 48 hours. That means if it is less than 48 hours, then we'll call it transient organ failure. Either it will respiratory, cardio, or renal. We'll define it later on. I will show you. So if there is a transient organ failure, we call it moderately severe. And if there is a persistent organ failure, single or multiple, then we call it severe pancreatitis, acute pancreatitis, and mortality is quite high. At the same time, you have to look for the local complications like peripancreatic fluid collection, pancreatic or peripancreatic necrosis, pseudocyst, wall-lock necrosis, gastric outlet obstruction, splenic and portal vein thrombosis, and colonic necrosis. These are the added things you have to look into the CT scan or imaging modality. I will discuss this one by one later on. So, in a nutshell, if you have to divide this acute pancreatitis, there will be two phases. That means in early phases, why you are dividing this phases? Because our priority of treatment, goal-directed therapy, is different in early hours and the late phase as well. So, it early we define in the first week, late after first week. Similarly, severity-wise, mild, moderate, and severe, no organ failure, transient organ failure, persistent organ failure. That means lasting more than 48 hours. And two types, edematous and necrotizing. If there is no necrosis, then we call it edematous. And if there is a necrosis in the pancreas of any sort, it is less than 30%, more than 30%, then we call it necrotizing pancreatitis. So complication-wise as well, it is very important to know this nomenclature. And apart from this nomenclature, other part like hemorrhagic pancreatitis, any other type of pancreatitis, now it is absolute. So you have to divide into edematous and necrotizing. Similarly, in case of edematous, the complication we get, that is, if it is in less than 4 weeks time, we call it acute peripancreatic collection. That means any collection around the pancreas. If there is no necrosis, we call it acute peripancreatic collection. And if it is more than 4 weeks, in edematous pancreatitis, dust collection we call pseudocyst. Similarly, if there is a necrosis and less than 4 weeks and there is a collection, we call it acute necrotic collection. And if it is more than 4 weeks and it is necrotizing pancreatitis, we call it world of necrosis. So these terminology are very, very important, and you have to keep in mind other terminology is not validated. So you should not be confused between pseudocyst and world of necrosis, peripancreatic collection versus necrotic collection, because this will determine the outcome of your patient in a particular subset. So that we have divided interstitial or edematous pancreatitis and necrotizing pancreatitis. So there is in interstitial, there is inflammation. 90% of acute pancreatitis is of interstitial variety. 20%, more than 20% having mild severity, and may lead to pseudocyst, and mortality is low, that is almost only 2%. But if it is necrotizing pancreatitis, the inflammation with necrosis, 10% acute pancreatitis coming to that group, and it usually tends to have moderate to severe pancreatitis, and it will lead world of pancreatic necrosis. So this is, have to remember you, the type and outcome. Similarly, in one slides, I also elaborate this thing because there should not be any confusion. Repeatedly, I am telling you, the division is between interstitial and necrotizing. It is important, as I have shown you in the mortality part. If you are dealing with interstitial or edematous pancreatitis, outcome is pretty good. So this sort of nomenclature and classification, duration-wise, you have to remember. That is less than 4-week acute peripancreatic collection, more than 4-week we call pseudocyst. So similarly in necrotizing variety, acute necrotic collection, and if it is more than 4 weeks, same thing become world of necrosis. There is a well-formed wall. These are the different imaging. With the arrow, you can see in the picture, there is a peripancreatic collection. There is a, with this arrow, you can see in lot of patient in your department level, you can go and discuss with the things. Now, in the management part, which is called golden hour, you used to use this term because it is a fluid sequestration is there. There is inflammation. It behaves like a burn patient. So a lot of fluid sequestration, intravascular dehydration, transient or persistent organ failure, and these are the most crucial out. And after 1 week, we usually deal with the sepsis, shock, or multisystem organ failure. And if your patient goes beyond few weeks, then the complication presented with the different like collection and sepsis. So as the intensivist, critical care people, we always like to manage this patient in the early hour so that the organ function should not be persistent, or there should not be, your patient should not be going into the multi-organ failure. So that's golden hour. It is very, very important in case of acute pancreatitis. Basically, the fluid management part we're going to discuss. So in assessment part, there is a lot of scoring system. Apart from what we do in the critical care area with other patients like SOFA, Apache, SUS, additional thing like we used to do the Ranson or Glasgow, BISWA, modified Marshall scoring system, and specifically the CT severity index and intraabdominal pressure. Out of all this, if you have to choose one quick one, like you can do very easily, that is the BISWA, and modified Marshall is very, very practical. And once you are able to do the CT scan, that will definitely measure the severity, and you can assess your patient how it's going to help you. And above all, the important parameter, usually it is very, very specific to pancreatitis. If you, but don't forget to mention in your file if you are seeing any patient of pancreatitis apart from this BISWA or SUS, which is very quick to do, you must have to do this modified Marshall organ failure score. That includes the C system, cardiovascular, renal, and respiratory. That means you are measuring the systolic blood pressure, serum creatinine, and respiratory, that is PO2 FI2 ratio. So you score like 0, 1, 2, 3, and 4, like more than 90, less than 90, but fluid responsive, less than 90, not fluid responsive, less than 90, pH less than 7.3, and less than 90, pH 7.4. Similarly, score 0.
ठीक है सर, मिलते हैं फिर.
Pardon? Anything? Okay. So similarly, renal part less than 1.4, 1.4 to 1.8, 1.9 to 3.6. And similarly, if it is score 4, that means 4 point more than 4.9. PO2 and FI2 ratio takes like 400, 3 to 400, 2 to 300. And if anything less than 100, we score 4. That means more the modified Marshall score, more is the organ failure, and outcome is poor. So that part we can do in initial hour. So that means what we have covered, that we have defined pancreatitis. Etiology we know, the common etiology we have discussed. Then we have discussed the how we'll assess your patient. This patient is how sick and what will be the outcome, what will be the complications. Now the management part we can discussing the intensivist. We are more concerned about the how we handle this critically ill patient. So first and foremost thing which can change the outcome of this pancreatitis, it is the fluid management. Basically, in this golden hours, first 24 hours is very, very important because as we have discussed, there is a fluid sequestration, third space loss, SIRS, GI loss, retroperitoneal hematoma in some cases, decreased preload, and impaired cardiac contractility. All these things will make the patient more dehydrated and sequestrated. So why fluid is so important? As we discussed, because of this vomiting, poor intake, typhoresis, increased respiratory loss, along with increased vascular permeability, pancreatic edema, third space loss, all will cause the hypovolemia, reflected by raised hematocrit and BUN, hypoperfusion of the microvascular, which will lead to the cell death, SIRS, ongoing release of pancreatic enzyme, pancreatic necrosis, increase interstitial permeability, and bacterial translocation at the same time, increasing the risk of infection as well. So fluid is very, very important. Now the guideline of the fluid, it has changed. There is a change. Initial concept, aggressive fluid management, then come the moderate, then it is called gold-reacted fluid therapy. Then we come to the waterfall trial. So we'll invest some time in showing what is the actual management and how it being changed time to time. So 2018 AGA, when they recommended the early gold-reacted therapy, no recommendation made at that time. I'm citing this 2018 part, RL versus NS, but against the use of starch and colloid. So this concept become change. What change? They come to the point aggressive versus standard hydration. Aggressive means you are giving 20 ml per kg bolus, 20 ml per kg of the bolus, followed by 3 ml per kg per hour. That means that group is the aggressive group, and standard 10 ml per kg bolus, followed by 1.5 ml per kg per hour. That means 20 ml bolus means if there is a 50 kilo patient, that will 1 liter of fluid bolus followed by 150 ml per hour. Similarly, if your patient is 80 kg, that means you are giving 1.6 liter bolus followed by 240 ml per hour, the fluid in aggressive group. But in standard group, 10 ml and 1.5 ml. What they found it, this aggressive management is detrimental in few cases. But in last two citation, what they found and recommended, the ringer lactate is the fluid of choice, without any doubt. And gold-reacted therapy, what they find it out 5 to 10 ml per kg body weight or 20 ml per kg bolus, then 3 ml per kg per hour. Lactate has a direct anti-inflammatory effect via GPR1 receptor and hypochloramic acidosis induced by infusion of large amount of normal saline with increased risk of kidney injury, and ringer lactate leads to significantly reduced rate of acidosis with a reverse correlation of bicarbonate to CRP level. That means these facts are being established, and apart from this aggressive versus standard, other part is acceptable and it is recommended till now. What is? That is ringer lactate is the choice. Why it is a choice? Because if you are giving that much of normal saline, particularly in that group, there is a chance of hypochloramic metabolic acidosis leading to kidney injury. And lactate has an additional effect, that is anti-inflammatory effect, GPR81 receptor. And ringer lactate leads to significantly reduced rate of acidosis. These are the beneficial effects. So these doubts are not there. But the controversy going on with the amount of fluids in the golden hour, and how will response to the fluid resuscitation, this monitoring has to be there. And in this study, what they found, the non-invasive clinical target like heart rate less than 120, MAP between 65 to 85, and urine output between 0.5 to 1 ml per kg per hour. And if you are reaching the invasive clinical target, stroke volume variation, intrathoracic blood volume determination, and biochemical target of hematocrit 35 to 44%. Nowadays, I will discuss here a lot of changes in the monitoring system in which we can monitor the basically the stroke volume, cardiac output, systemic vascular resistance, tissue perfusion. So a lot of advancement is there, which were not earlier 7 year, 8 year, 10 years back. So finally, they concluded the early aggressive IV hydration with ringer lactate solution hastened clinical improvement in patients with mild acute pancreatitis. That means this is a established fact. In mild acute pancreatitis, aggressive fluid management has the role and has clinical benefit. But same thing is not applicable in case of the severe acute pancreatitis. And why? These are the different studies done. I'm not going in detail of that. But if you take this meta-analysis of RCT and cohort studies, when is there aggressive IV fluid resuscitation beneficial in acute pancreatitis? So 11 studies, 2686%, 1256 aggressive versus 1430 standard. What they found, no significant difference in mortality between the two groups. Patients receiving the aggressive IV fluid, higher risk of AKI and ARDS, no significant difference in overall incidence of SUS, organ failure, or pancreatic necrosis. Now the final part, the concluding part. You must be aware of this waterfall trial, that is aggressive or moderate fluid resuscitation in acute pancreatitis. And this waterfall trial, which is hold good for till now, that was this trial you must read and must go through the detail. This is designed as a multi-center, open-label, randomized control trial. It was basically a superiority trial across 18 centers in 4 countries, including India, Italy, Mexico, and Spain. So consecutive patient with clinical suspicion of acute pancreatitis in emergency room, and they have participated in the study. May 2020 to September 2021, total 676 patients with acute pancreatitis were assessed. 249 were randomly assigned. Aggressive resuscitation in 122 and moderate resuscitation group was 127. So I am discussing the important finding with the value. You must go with the detail of the study. It is a landmark trial, and we have just changed the management protocol, IV fluid management in the initial hours. So this trial showed that aggressive fluid resuscitation increased the risk of volume overload. Given data showing increased harm without improvement with regard to primary outcome, the Data and Safety Monitoring Board unanimously recommended that the trial to be stopped. And aggressive fluid regime was associated with a tendency towards a higher intensity of symptoms and longer duration of hospital stay and a higher incidence of necrotizing pancreatitis than the moderate fluid resuscitation. At the same time, pancreatitis thing is associated with increased intravenous pressure, which may be worsened by excessive intravenous fluid. So the conclusion of the study was that aggressive fluid management is out. Basically, in case of severe acute pancreatitis, we don't go for the aggressive fluid management. But yes, in mild cases, still there is a beneficial effect, some beneficial effects seen in the mild acute pancreatitis. But the goal-directed moderate fluid resuscitation is recommended, and definitely the ringer lactate I have discussed is the fluid of choice. So this part from the fluid. Now the concluding part is that if there is no otherwise contraindicated, if your electrolytes is fine, and you have a liberty to choose a fluid. Then ringer lactate is the choice. Why we have discussed. Moderate resuscitation is recommended. It is goal directed and should be monitored according to your parameter. And if it is severe acute pancreatitis, the recommendation after this waterfall trial is not go for the aggressive fluid management. Now these are the part and parcel of the ITU care. We are not going to detail that is IVC and CVP. So IVC is something we can go for, but if your internal pressure is very high, both the cases, that is CVP will be not so much useful, but yes, IVC can be helpful in all these cases. What I want to discuss, this is the thing that is monitoring in golden hour, that is intra-abdominal pressure. This is something you must have to try if it is feasible in your unit. We have done one study also, I will show you later on. There is a kit from some company that is a Bhajer kit. This is basically we are putting a catheter. You can see this one catheter. With this trilumen catheter, one end we are transducing with the thing, and the second thing is that basically we are measuring the intravesical pressure, which is indirectly measuring the intra-abdominal pressure. So that is very, very important. If this set is not available, then you can do in a conventional method with the help of this ruler and zero reference point. What we do, make a three-way Polish catheter, make one PM line and transducer, connect to your CVP line, make a neutral position, and can take the reading as well. This is another alternative method, but if you has availability of this advisor set, it is a very, very beautiful method, and you can even measure intermittently many times the internal pressure. It is very, very important outcome, whatever we see clinically. Any internal pressure, if it is more than 20, we call it compartment syndrome, and you have to keep the abdomen open. Just you have to keep the open. Otherwise, you cannot make your patient survive. So this is something which is very, very important. And we have done a paper, it is being published in Pancreas 2020. So what we do, the role of static and dynamic intra-abdominal pressure monitoring in acute pancreatitis, and it was a prospective study. I was involved in this study we did in our ITU, and we concluded that the static intra-abdominal pressure is an easy, useful, and inexpensive method to determine and predict the mortality of acute pancreatitis. However, if you do it early and accordingly you change the management plan, the outcome are quite different and significant effect we have found. At the same time, some cases who needs the basically laparostomy, you make a hole even in the back side and keep it open. It will help to decrease the internal pressure and will prevent the organ failure as well. So these are the monitoring system we must be aware of in the golden hour. So the ABG is must, which may have the mirror of ICU. Sometimes you need like a high-end monitor in which you can like transpulmonary thermodilution technique using the measuring the cardiac output, systemic vascular resistance and hypoxemia, tissue perfusion you can assess. So I'm not going into the detail of the monitoring system, but what we have to look for, the different organ failure. First and foremost, that is the hypoxemia and respiratory failure. It may be atelectasis, ARDS, pleural effusion, edema, or aspiration pneumonia. So we have the amenities. We try to do with the NIV. If it is not NIV, then invasive ventilation, according to the merit of the situation. In some cases, we nuke the fluid removal in unstable condition with CRRT machines. So this was the part of fluid management. We have discussed the internal pressure management and some invasive monitoring and the support system. Now we come to the next thing, the antibiotic in acute pancreatitis. So I must say there is no role of antibiotic in initial hour in acute pancreatitis. There is no role. It is clear cut evidence. There is no role. But where you think for antibiotic, few conditions. The potential use in prophylaxis prevent the infection in necrotizing pancreatitis. Definitely not in the first week because now necrotizing pancreatitis is evolving within hours. So please, if it is acute pancreatitis, count is 30,000, patient is having fever, don't jump into the antibiotics. There is no role of any antibiotic or any prophylaxis. Only if it is a week later, it is a necrotizing pancreatitis, in some study has shown some benefit, or if you have the documented evidence of infected internal collection, that is even after 7 days or in second week, then there is a role of antibiotic. Otherwise, in initial hour, in first week of therapy or first few days, there is no role of antibiotic in acute pancreatitis. Please don't go with the thing. But yes, if you think there's UTI or community-acquired pneumonia or skin tissue infection, anything other than acute pancreatitis, in that case you may add antibiotic. But per se for acute pancreatitis, there is no role unless it has been complicated with sepsis. So what data suggests? Infectious complication affect 32% of acute pancreatitis cases. Commonly respiratory infection 9.2% or bacteriemia 8.4%. And about 50% of bacterial cultures from necrotic pancreatic tissue are of non-enteric origin, suggestive of infection from the extrapancreatic source. That is very, very important. If you are suspecting a patient is having UTI or patient is having respiratory chest infection, anything else, or ventilator VAP or pneumonia, in that case is different. And extrapancreatic infections should be identified as soon as possible. Now, if you have to give the antibiotic, what antibiotic you choose? So we have to choose the drugs that achieve the high concentration in pancreatic tissue, like imipenem and meropenem, metronidazole, fluoroquinolones. But if you are going giving like amikacin or another drugs, some drugs do not have any penetration in the pancreas. So we have to be very, very careful while choosing your antibiotic. So aminoglycoside, beta-lactam penetrate very poorly in the pancreatic tissue. So now the antibiotic part is clear. In the first initial hours, in the first week, there is no role of any prophylaxis or of antibiotic or treatment of pancreatitis. If you're thinking for the other infection, then you can add. And if you are adding antibiotic in second week or after 1 week or for infected pancreatic collection or necrotizing pancreatitis with infection, then we have to choose the suitable like carbapenems, metronidazole, and we have shown the others. Now we are going to the next part, that is the nutritional supplementation. It is very, very important whenever you
IJMC Nagpurla.
pardon?
Indira Gandhi.
Someone else, please mute yourself. Okay, so now we are moving into the next one, that is the nutritional supplementation. Nutrition is something you have to be taken care of. You have to be taken care of because it is one of, as I have told you, the one or two things which can change the outcome of pancreatitis, severe pancreatitis or acute severe pancreatitis. It is first and foremost thing is fluid, and second thing is nutrition. Then how quickly you can go for nutrition. In mild cases, there is no major issue because you can start it orally, oral liquids, and gradually you can build up. Even in moderate cases, no problem. But those patients who are really very sick with organ failure, requiring ventilator support, CRRT, or advanced monitoring support, there is internal hypertension. In that case, nutrition has become really, really problem. So there is no debate between enteral or parenteral nutrition. I always say these are not the antagonism. This is the synergism of the effect. Synergism, that means there is a synergistic effect. How much you can start with enteral, you must try with the enteral feeding. And if you are unable to maintain the calorie, if your patient is on mechanical ventilation requiring renal RRT, and your calorie requirement, it is in catabolic state. Your calorie requirement, you are calculating 1500, 1600, and you are only able to give this 500 or 600, definitely your patient will be worsening. So whatever the way you can, you have to feed. So choice is always enteral, we should try. And if it is enteral, it is between, you can try with nasogastric or nasojejunal tube. And I must tell you, something about this nasojejunal tube. Most of the studies suggesting that nasojejunal versus nasogastric tube have no much difference. But I will highlight the few cases where this nasojejunal tube have advantage. Being in critical care area, if you are working seriously, you can see if you are using this nasojejunal trilumina tube, one of the name you can go for that is Freca trilumina. So this nasojejunal tube have two variety. One is a double lumen, when one lumen in the gastric, one is decompression, and trilumen, that means one port in the jejunum, one in the gastric for aspirate, and one in the decompression port. So if you are using the trilumina tube, three port, that means you are able to fit with the jejunal port. Gastric port we can make aspiration, and for decompression there is a separate port. So gastric port, if your patient has a gastric outlet obstruction, output is 1.52 liter, even you can feed your patient with this trilumina feeding tube. So it is very, very important, but you require some skill to put it. Usually we put under Siam, so check the position, it is in the jejunum, and sometimes you must have to put with the endoscopic method, but most of the time, 99% time, we will be able to put under CM guidance. So, in case if your patient is having type 2 respiratory failure, you are unable to move this mask and a lot of aerophagia, you have to make the gastric port open in all these cases. And those with having gastric outlet obstruction, when the gastric aspirate or RT aspirate is 1000, 2000. In that case, even this is very, very beneficial. And this is a game changer, I must tell you, if you are able to do it at proper time. And finally, if your internal pressure is so high or ileus is there, the patient is not tolerating there, please don't hesitate to start with the TPN. Don't count day, it is not a 7-day or 5-day like the things. After 72 hours of stabilization from day 4 or 5, you must have to go for a nutrition. But yes, you have to calculate, you should not go in when a refeeding syndrome, underfeeding or hyperfeeding as well. So now I'm clear, we have to start with enteral. If you're not sufficient with enteral, you may have to go for the parenteral nutrition. You can combine it, which is called supplemental parenteral nutrition. And if you have the facility to put this nasojejunal tube, you must try. It is a advantage over nasogastric tube in many cases. But if it is tolerable, if RTS rate is less, then you can even consider for the nasogastric tube feeding in your patient. Now the next aspect that is very, very important from the patient perspective, patient will not ask you what is the complication, how you are managing. They are only bothered about their pain management. So that has a drastic change, and your ICU said to be good if you are good enough in tackling this pain management. So apart from this WHO letter, what you usually escalate in our patient, like step 1 NSAID, step 2 low steroid, low potent steroid, opioids, step 3 high potent opioids, and step 4 interventional treatment. So this is the WHO letter we follow. But more of the clinical setting, what you use, it is the tramadol, which are commonly being used. But we recommend you must try for the patient control analgesia. And this patient control analgesia has a very, very good patient satisfaction. So if possible, you can try it. If you have the facility of patient control analgesia, just you put with some fentanyl and you give the intermittent dose. It is as good as anything. And if you don't have the facility, in most of the situation, you use the safer is the tramadol hydrochloride. But there is advancement in this part also. People are using the epidural part, epidural analgesia, technically a bit demanding, but yes, we can take care of the part if you are expert on it, put epidural catheter and give your continuous analgesia. And for the pain relief, that is, if your patient is having gallstone, pancreatitis, and there is a CVD stone, or patient is having cholangitis, cholangitic type of pain, so in that case, ERCP is required and it will relieve the pain. Otherwise, patient will be suffering. So there is only one indication if I have to tell in acute pancreatitis requiring ERCP, it is the cholangitis. Apart from the cholangitis, we have to go conservative. So I think in pain management we are clear. We are starting with the opioids, usually in the tramadol or fentanyl is the safer one. Sometimes thoracic epidural, but patient controlled analgesia is very good, and ERCP in cholangitic pain. These are the different devices. This you can use the patch, you can use the subdural set, you can use the patient control analgesia in the forms. Now the last part of the session, that is how you will manage your patient if there are multiple collection, peripancreatic collection, wall of pancreatic necrosis. In that case, we usually no surgeon want to operate your pancreatitis patient, whatever the pancreatic necrosis in older days, because they believe, and it is true point, that you do not get and just get out of the pancreatic tissue and necrotic tissue and come out. It requires multiple sessions. So multiple surgeries is usually not possible, and outcome is very bad. So surgeons are really scared of, and we also don't want. And surgery is the only option after 4 weeks. Before 4 weeks, you cannot go into the surgery unless indicated otherwise. So the good method we tried the endoscopic therapy, and I will show you some part how we'll go it endoscopically. That is transgastric drainage and sinus tract endoscopy. This is a transgastric drainage. You can see that means if any pancreatitis having a peripancreatic collection and making a bulge in the stomach like this is a bulge in the stomach, a big bulge from outside. You can appreciate in CT scan. Then you make a small nick there, make a guide wire, put a guide wire, then put this stent. This is called Nagi stent, like banana shaped. A loss of pus come out, and this drainage is called cystogastric drainage. That means there is a combination between the cyst and the stomach, and all the drainages become within the stomach. So it is called transgastric drainage. Similarly, the sinus tract endoscopy, it is very tedious job, but we usually do when your surgeon is not taking your case. It is on 4th week, a lot of necrosis. Then you have to put a external CT guided drain. That is a big drain. That means 32 French drain, so that your endoscope after 7 to 10 days you are going through the endoscope from that drain area and making a necrosectomy, like a surgical part we can do. So it is called endoscopic necrosectomy, but it is a time taking and multiple session is required. This is the technique. You put out the drain after 7 to 10 days, track is mature. Then you put your endoscope, and these are the material you have to make it out from different accessories. And finally, it looks like that one. These are the necrotic tissue, a lot of necrotic tissue you can appreciate. So these are some finest method, endoscoping method. We are very useful in case of necrosis. Surgical intervention, as I have told you, if internal pressure is very high, more than 20, so you have to do the laparostomy. Just making a stoma-like of things, and you are wrapping a paper over sterile, sit there and keep it like open. And when the internal pressure goes down, you can make it a closure. So this is an emergency situation in day 2, 3, 4, like a first week. But if it is in the 4th week, you are going for pancreatic necrosectomy. That is again a bigger surgery. Some role of intervention radiology is there. If you are dealing with a large collection, sometimes to decrease the internal pressure, you have to go for drainage, image guided drainage. Pleural effusion is there. You can go take help of the intervention radiology. Sometimes we get the necrosis, bleeding, pancreatic, sometimes angioembolization. A lot of things required in advanced center. We have, if you have the facility of intervention radiology, they can help you out in the management of this acute pancreatitis. This is a big domain and subject, so I don't have too much time to discuss this intervention radiology, but you have to keep in mind, you can take their help in early hours to reduce the internal pressure, drain out the pleural fluids and all, and in the later half, in the drainage of peripancreatic collection. When you are unable to assess endoscopically, the intervention radiology can do the miracle. These are the things you can see. US has an additional role. That means you can identify the collection, you can know the vasculature, vascular pattern, and US guided things are bit safe, better. You can locate the things. You can assess the wall formation, wall thickness. You can US guided stenting is also possible. We do regularly. So this is another domain. And last part, that is the artificial intelligence. I must tell you now, in coming days, if your patient is coming to the emergency area, if you are writing the patient symptoms, available lab reports, lab reports, imagings, then definitely we will getting a chart. This patient is most probably having mild pancreatitis or moderate or severe pancreatitis, and that will be the management plan. So to predict the hemodynamic changes, you can take help of this artificial intelligence. And coming day must be there. There must be some software definitely, and you can process. You can process, that is, it will be a process of incorporating large amount of disparate data into a unified algorithm, which then is used to predict and solve the clinical problem. So they must will be guiding something. An example of their application will be like image processing of radiological images, analysis of whole slide pathology, fully automated echocardiogram interpretation, text analysis of clinical notes, and artificial intelligence has the potential to be incorporated into the clinical decision support system and to help the clinician adhere to the practice guideline at the bedside. So it is a coming thing. We are taking help of artificial intelligence in some colonoscopic cases and some detection of the polyps and all. And I must believe in coming time, this artificial intelligence will be acting as a teacher. And if you put all the data, history available, investigation available, radical feature available, and all the scoring system, if you put there, then ultimately they will give you a seat, the probable line of management of this pancreatitis, and definitely for the newcomers or the budding intensivist gastroenterologist that may be acts as a boom. Thank you. This is a summary. If I told, repetition will be there. That is quick assessment of severity, invasive advanced monitoring of the severe acute pancreatitis, initial hour of IV fluid, pain relief is must, as I have told you, antibiotic in only selected cases, DVT prophylaxis and glycemic control as per ICU protocol. Nutrition supplementation is not optional, that it should be a must thing. Timely radical endoscopic or surgical intervention as and when required. And definitely it's a teamwork. It's required intensivist in the center point, because in initial days it is only intensivist. Definitely with support of colleagues, gastroenterologists, interventional radiologist, nutritionist, dietitian, physiotherapist, pulmonologist, nephrologist. So I must say it is a teamwork, and this is one of the case that is required every specialty to be together. Thank you. Thank you for your hearing. And if you have any questions, we can discuss now. Thank you.
Thank you, sir. So we have questions in the chat box. I would like to ask Dr. BISWA BIKASH Mohanty ji and Indrajeet Tiwary to please answer those.
Yeah, I think of very good evening. I think it's an excellent talk by Dr. Tiwary. I think he's the best person and to summarize the acute pancreatitis in such a small time. As an excellent talk. First of all, thanks Dr. Tiwary for giving such a nice talk. I think Dr. Tiwary, we have some questions in the chat box.
Yeah.
So I'll read for you and I will answer. So the first question, somebody and from the Indonesia. The question is, what strategies can be employed to prevent complications such as pancreatic necrosis in critically ill patient?
Yeah, very good question. Initially, I have make you concluded two things which can totally change the outcome of this acute pancreatitis is first and foremost is the fluid therapy, and second is the nutritional therapy. Fluid is something that I have always tried to emphasize, like a golden hour in cerebral stroke, in AMI. Similarly, we call it golden hour in acute pancreatitis. The first 24 hours, first 6 hours to 8 hours of management of this fluid is very, very crucial, which can prevent the like your organ failure. And now doubts has been clear with this waterfall trial. We are not
Yeah.
going for aggressive fluid management in case of severe pancreatitis, but yes, goal directed. And if you have a monitoring system and we can monitor the stroke volume, cardiac output, tissue oxygenation, and IBC, you can be more goal directed fluid rather than going blind aggressive fluid management, which will be detrimental in case of severe acute pancreatitis.
Yeah, thank you. One more question. Can pancreatitis increase the risk of malignancy?
No, 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 no. The acute pancreatitis do not increase the risk of malignancy.
Yeah.
But in case of chronic or recurrent acute leading to the chronic pancreatitis, in some literature showing there is a chance of malignant potential, but acute pancreatitis, definitely no.
No. One more question is optimal approach to provide nutritional support in this case. I think you have
Yeah,
already answered.
I'm adding one line to that. Nutrition is not a choice. You have to address nutrition as a medicine because,
Yeah,
as I have told you, in first 3 days, 4 days, fine, 72-hour time you are stabilizing your patient. But suppose you are doing fast for yourself for 3 days, how you can feel at the day four if you are not taking any calorie? You are a normal person, and if you are not taking anything for 3 days,
yeah,
how your body will behave? But in
sure.
that case, since you are in a mechanical ventilation, dialysis, and all these things, body requirement is same. So you have to calculate the negative nitrogen
Yeah,
balance. What is the deficit of 3 days or last 4 days? Then you try to give at a addition of 25% each. Don't go with a 100% target. Try to increase in a level of 25, 25, 25. So what we do, if it is not possible or only very sick patient, I am asking for the very sick patient, those are on mechanical ventilation, CRRT, and all these things. We try with only 25 ml of RT feed or nasogastric feed, even RT feed. It will act as a trophic feeding and it will prevent the translocation of bacteria as well and prevent the infection. So 25 ml is also good. And if you are unable to increase, you just add the TPN. Now the concept of supplemental parenteral nutrition is there. What is supplemental parenteral nutrition? If you are unable to achieve your target by nutritional target by 22 hours, then you have to add this parenteral nutrition. So it is called supplemental parenteral nutrition. Not you are giving total, but it is a supplemental. So concept of the supplemental parenteral nutrition should be there. And I must talk. I talk in every seminar. You don't argue with enteral versus parenteral. They are not antagonistic.
no
They
question.
must
Yeah,
have synergistic effect and should
yeah,
be considered along with.
yeah. Excellent. Uh, One question somebody is asking, when should you considering operative strategies for pancreatitis? I think you have already discussed the role of
Operation is
surgery.
out of context. Only two
Yeah,
indication of operation. I have told you,
yeah,
no surgeon is going to touch your acute pancreatitis
yeah,
unless it is 4 weeks later. And second, only early hour in bedside itself, if it is a very high intraabdominal pressure, that is
yeah.
compartment syndrome, then
Mm,
laparostomy, making a
yeah,
stomach or creating a hole in the stomach to release the intraabdominal pressure. That is the only intervention you can make in early hours of pancreatitis.
yeah. Thanks. Somebody is asking role of pain management in the acute pancreatitis intensive care unit. I think already you have discussed, like
Yes.
OPER, you are telling tramadol and somewhere repeater analgesia. Yeah.
Pressure glucose analysis is a beautiful thing you can try if you have the facility.
So yeah, only thing is here I can highlight sometimes what happen in like we the intensivist, sometimes we go with high dose of opioid and to control the analgesia sometimes we get some downside of the opioid, maybe patients present with like constipation, bowel dilatation. If these patients already having high intraabdominal pressure, that can add, and
Yeah.
aggressive fluid dissociation sometimes bowel edema can add to this. So that in that cases we have to be little bit cautious. Otherwise, opioid is the
So
best
we
analgesia
recommend
for.
usually the multimodal analgesia
Yeah,
rather than a
yeah,
single modal. So multimodal, we're trying with the NSAID, then you can go with the low opioids, low dose opioids, then you can
yeah.
gradually increase. Yeah.
Yeah, so somebody is asking how effective are the scoring systems like Apache, SOFA, BIPA, BICEP in predicting mortality in ICU patients?
That we have already discussed in my first slide. That is,
Yeah,
Apache SOFA you do is for the regular, or SUS you do for regular
yeah,
patient.
yeah,
That has the same benefit as you get in other ICU patient.
yeah,
But
yeah, yeah,
specifically for pancreatitis, you must do this modified Marshall scoring system, which can
mm,
predict the organ failure, which is transient or persistent in nature, and that will determine your outcome. So modified Marshall score, and very easy to do the BISWA score in the bedside.
yeah,
So BISWA and modified Marshall is something. And once you getting a CT scan, then definitely CT scan index. And if you
yeah,
have the facility for this intraabdominal pressure monitoring system, as I have shown my paper, that is a very, very good thing to do if you have
yeah,
the
yeah. I
facility.
have gone through.
But
Yeah.
yes, at emergency, very good thing. Apache and SOFA will give you the information. Modified
Mm,
Marshall and BISWA is doable, and we usually do in our ITU as well.
sure. So somebody is asking like if there is some gastric outlet obstruction or ileus, how to go ahead with the enteral feeding?
That's why I'm told you, you have
Yeah,
to use the Fleca trilumina.
yeah.
That is, nasojejunal trilumina tube has a benefit. There's a three lumen. One port is going into the jejunum. You continue feeding. One port is lying on the gastric
Mm,
port, so you make a continuous aspiration. It may be 2 liter, but you are able to feed with this nasojejunal tube. And third is a decompression port for the giving the stuffiness. You can remove this.
yeah.
That is the specific benefit in case of gastric outlet obstruction. Otherwise, with two lumen tube, you are unable to feed. With nasogastric tube, you are unable to feed if your gastric outlet obstruction and aspiration is more than 2 liter, 2.5 liter. So that is the best thing and a specific indication of this trilumina nasojejunal tube. And that is a change the entire history of acute pancreatitis, management of pancreatitis.
Someone is asking when the MAP is less than 65, will you stop feeding? The answer is actually we are the intensivist. Usually, you see, if a patient is very low dose inotrope to maintain the MAP, usually you don't stop feeding. But
Yes.
if patient's inotrope is increasing very high and simultaneously ABG is acidotic and patient's lactate is high, in that cases, we usually think of holding enteral feeding. Otherwise, if a patient is very low inotrope with maintaining MAP 65, usually don't stop
Noise.
feeding. Yeah,
Definitely noise. Nutrition do not have any
yeah,
contraindication in the map of
yeah,
65 and more. But yes, if it is a bowel ischemia, if it is
yeah.
impending ischemia, internal pressure
Yeah.
is very high, then you
Mm.
cannot make more injury in a injurious horse. You cannot go in feeding. But in most of the situation, yes, we can.
Somebody is asking what antifungal are good in acute pancreatitis. I can answer. So usually for acute pancreatitis, empirically we don't start antifungal. We start antifungal in acute pancreatitis, acute severe pancreatitis, if there is some risk factor, other risk factor for candida score. Like if the patient who have started TPN, as we have highlighted, we are not able to start enteral feeding, prolonged TPN, prolonged antibiotic therapy, and patient having CBC catheter, and if like we are going for some abdominal surgery, in that cases we think of starting antifungal. And among the antifungal, if the patient, usually you start with the like a fluconazole. If the patient is stable, usually you start with fluconazole. Sir, what is your take?
Yeah, definitely. Just you are absolutely right. Only to add on, please don't think for any antifungal for 2 weeks if there is no other indication. For
Exactly.
pancreatitis or necrotizing pancreatitis, please don't think anything, any antifungal prophylaxis per se.
Mm,
Dr. Monty has said, if you have the high candida score, colonization, high risk factor, that is another thing. But
yeah,
simply acute necrotizing pancreatitis 10 by 10, you do not need any antifungal antibiotic. Yes, if you document the necrotic tissue is infective, you start with the higher generation antibiotic. If it is non-responsive to the antibiotic, so antifungal treatment has three levels. Three level mean one is prophylaxis, one is
prophylaxis,
empirical, preemptive, and definitive.
definitely.
So prophylaxis, no for first 2 weeks. And if you have to give the prophylaxis after 2 weeks, then what Dr. Manti said, it is fluconazole, fluconazole. Fluconazole is the choice. But if your patient is in third week or 4 week, when you are praying sepsis, necrotizing, a lot of internal collection, high fever, you are suspecting or already given a some antibiotic. In that case, in hemodynamically unstable patient, third week or fourth of pancreatitis, your patient is looking septic. If you have to choose, the drug of choice is echinocandin. Either of the echinocandin, caspo, mica, or enveloping you can choose. So that is the protocol. But
Absolutely true,
no
sir.
prophylaxis or empirical role of this antifungal for first 2 weeks.
Somebody is asking, sir, when you will go for endoscopy to remove gallstone from the CBD, before it was within 48 hours.
CBD, generally only one indication for ERCP in acute pancreatitis, that is cholangitis. If there is a CBD stone not causing cholangitis, nobody is going to do the ERCP. Why? Because there is a lot of edema in the D1, D2 area, so you will be not able to succeed this pancreatitis. If you have to take any risk, that is the only clinical indication book teaching is there. If your patient is having cholangitis, then only touch the CBD stone. And for the gallstone, if it is mild to moderate, now the literature is coming in the same setting you can do before discharge. Or if it is severe pancreatitis, you have to wait for 4 to 6 weeks before handling the gallstone. But CBD stone, only indication is cholangitis.
Sir, somebody is asking how much of enteral fluid contribute to intravascular compartment in acute pancreatitis?
That is very, very excellent question. How much the interval will be. But the common concept is that whatever you give orally, it will not cause the heart failure. It will not cause the intravascular component to
Exactly.
go
Yeah.
up. But
Mm.
it depends how much it is getting absorbed. If I am
Yeah.
taking a lot of fluid, 2 liters of fluid, ultimately that fluid is coming to the intravascular space. Otherwise, how you daily maintain your outcome? Every day you are not taking fluid. You are taking only the intake is 2 liters or 3 liters, and it is coming out to your kidney and you are alive. Similarly, in pancreatitis, you have to add on. If you calculate the intake, if your patient is no fluid or no TPN, it is only RT feed 80 ml per hour. Where this fluid is going? It is going into the intravascular space. But yes, I know your question. You are asking how much it will be going in that critically ill patient. That we cannot calculate by any formula. Only thing you have to see three things: intake, output, hematocrit, and that sort of thing. How much of urine output, how much of albumin level, what is the edema, then you can make it.
Okay. So somebody's question asking pancreatitis increases chance of recurrence. Thing is, sir, as far as my knowledge is concerned, like if somebody is alcoholic pancreatitis and is taking alcohol continuously, that in that case it can recur. Apart from the TG induced, hyper TG induced pancreatitis may recur also. So
Yes.
your
Yeah. Pancreatitis, recurrent pancreatitis can be of different region. If patient is having pancreatic divisum, anatomical problem, then it may recur again and again. Autoimmune pancreatitis may recur again and again. If it IgG4, if it is gallstone disease not operated, may again. If it is alcoholic, not stopping alcohol, it may recurrent. But it is not necessary that if you have one pancreatitis, will be whole life will be exposed to the pancreatitis. If we have taken care of this utility factor better. So something is curable, like if it is gallstone, if you removing the gallstone, fine. If it is hypertriglyceridemia related, again it can be controllable. हाँ हो गया पाँच.
yeah.
Yeah, 5 more minutes, please. We can give 5
Just
more
we'll
minutes.
take one more question.
Yeah.
Somebody is asking NIV in mild to moderate ARDS in pancreatitis. Usually, NIV, the risk is in NIV, there may be like aspiration and bowel distension in that cases. Otherwise, if the abdomen is okay, in that cases with low pressure, we can start NIV because it has some splinting effect in the lungs like mild to moderate ARDS. In that cases, NIV we can give, provided you are not there is leak and you are giving so much pressure, so that was bowel getting distended and it is adding your intra-abdominal pressure.
Exactly. The only difference is internal pressure. Increase in
Pressure.
internal pressure should not be there. Otherwise, it will be detrimental. Otherwise, in normal cases, what we try to take care with NIV. If it is failed, then only we go for the invasive part. Yeah.
Okay, sir. Last question will take so role of ulinastatin.
I have used a lot of university. I have used a lot, and I try
Yeah,
to make some papers also. In
yeah.
my, if you go with the book teaching or the published paper, there is no recommendation to have proven benefit in the acute pancreatitis. But in my personal experience, whatever data I have collected, if you are using in early hour means when your patient is presenting in early hour, 48 hours, 72 hours, or even in post-acute pancreatitis. In some cases, we have seen some effect, but yes, in that forum, I will not recommend because it should not be my opinion and my personal experience. Current literature do not suggest or do not favor any uh, beneficial effect of this inelastin in acute pancreatitis.
Okay, sir. I think we have discussed all the questions, and thank you so much, sir, for
Thank you.
such a excellent session. Even we learned a lot from you, sir.
No, thank you.
I think it's a fruitful for all our attendees. And thank you, sir.
Thank you. Thank you very much.
Thank you, sir. Thank you, doctors. It was a very nice session. We like to see you more in these session too. Thank you.